All right, back in business.
All right, sounds good. Are we waiting for anybody else here? Should we get started? Okay, great. Hello. I'm Casey Davidson, and I am the outreach liaison with the Grace Hospice Care. I've been with the Grace about 4.5 years now. And I just came today to talk a little bit about how we work together, what our interface looks like sometimes. I won't say it always looks like this, but this is what we strive for. This is how we want to work together. And this whole idea kind of started about 2.5 years ago now. We had an encounter with a patient of ours who encountered the Madison Police Department in their home. And what we all took from that is that we all can and should be working together better to make sure that this resident and this patient of ours was served in the way that we all strive for them to be served. And so that's kind of how this idea came about. And so now here we are, a couple years later, we're still talking about it. There's been a couple initiatives that have come out of this that I will touch on today. But for the most part, I really want some feedback from you all. So if there's any point where I'm talking about something and you have something burning to add to the discussion, please do. And we can kind of talk through some of these things together. So, all right. I'm going to start just by telling you a little bit about Grace and who we are. So we were founded in 1978. We are a nonprofit hospice care organization. We have been from day one. And that's something that we're really proud of. We really operate on this idea that as the nonprofit hospice, we take care of everybody. We take care of everybody regardless of their ability to pay, regardless of their origin, regardless of where they come from, who their family is, what their social economic status is. That's something that's really important to us, that we represent our community. So we are community supported as well as being a nonprofit. That's who keeps our doors open, is this community and the generous donations of this community. So we are very committed to really being the best option for people here in town. We do serve 20 counties now, which is pretty amazing. The majority of them you can see here in south central Wisconsin. The other, let's see, what is it now? 6 counties in northern Illinois. That has been our most recent expansion. We have offices in Madison where we have an inpatient unit. I'm sure most of you are familiar. We have offices in Janesville where we also have an inpatient unit. That inpatient unit is 12 beds. Here in Madison we have 50. So that gives you...
the one on East Sherrill?
Yes,
okay.
Yes.
So
East Sherrill, yes. And then we have a Baraboo office and a Rockford office, and those are both satellite offices. There's no inpatient unit. We take care of about 850 or more patients a day across our entire service area, and we have over 900 volunteers. Our volunteers make up a large number of what otherwise would be staff members. So that I think is pretty remarkable that people give of their time in that way. And then finally, we are an affiliate with UW Health and Unity Point Health Meritor. And we are their affiliate and have been for a couple years. Some of you may remember seeing that when that happened in the newspaper. So I'd just like to point that out for everybody. Okay, a little bit about what hospice care is and how we function. So we have this really unique blend of services. We have this unique blend of medical services, emotional services, psychosocial services, spiritual services, and we really look at the person as a whole. So that's the whole philosophy behind hospice. Yes, there are physical aspects that we are very concerned about as the dying process occurs, but there are also just as important emotional and spiritual aspects that we really try to hone in on with people. Anybody that has a life-limiting illness and a prognosis of 6 months or less, whose goal is comfort, not curative, but comfort care, is eligible for hospice. And so this looks different for a lot of different folks. This looks very different from a cancer diagnosis to somebody who's lived with COPD or CHF their entire life. But what remains the same are these goals of comfort care. We know we're not going to fix the problem anymore, but what we want to do is give ourselves the most quality of life that we can and really focus on our comfort. So that's the idea behind that. Okay. Where does hospice occur? So it can occur anywhere somebody lives, a home, an apartment, a long-term care facility. We've taken care of folks in homeless shelters and hotels. We've taken care of folks that have no home at all. And so it's really important to us, again, that we are meeting somebody where they're at. We aren't in the business of moving people from home to assisted living or home to nursing home unless that's a goal of theirs and safety is a concern. And I know you all think safety, safety, safety all the time. And so I think that's a lot where we come together to look at a person and decide, is this a safe situation for them to be receiving care? Okay. All right. When does someone call a grace? So we are looking at folks a lot of times that have multiple of these things going on. So they may have frequent ER visits, falls, they might have weight loss, they're sleeping more, they have lack of energy, and these things are sometimes really subtle. And sometimes they're hard to pick up on. So there's a lot of investigation that goes into these oftentimes. If somebody's been living at home with a spouse who's caring for them, who maybe also has their own things going on, these things like sleeping more, that might not be something that they pick up on very easily or very quickly. Well, no, my wife's just a little bit more tired lately. Not necessarily, they're not calling us and saying, she's sleeping a lot more. These are things that sometimes we do have to investigate. So there's lots of these. Uncontrolled pain is another one that we see a lot. People that'll call us and all of a sudden their pain has gone from, they've been living with it for a while at a 2 or a 3, and now we're at an 8 or a 9 and we're in a pain crisis. And they don't want to go to the hospital. They don't want to be admitted. They don't want more workup. These are some of the things that we're hearing. Okay. So any questions before I kind of move on to what this looks like in the house?
Well, I just want, so that your clients, patients, I mean, they need to contact you initially, correct? You don't go out there and, or communicate with hospitals or, someone needs to contact you and that's how the process gets started? That's
a great question. So who can make a referral? Anybody can. We get referrals from the hospitals very frequently. They've got somebody inpatient that's choosing comfort, that qualifies for hospice. The physicians have seen them. They agree. They call us and we'll go see them there and we'll help with discharge planning. We have gotten referrals from adult children, of course, as a big one. Spouses, big one. But we also get referrals from neighbors and senior centers. And, we actually, I'll give you an example, got a call from the Middleton EMS group a couple weeks ago. And they called and they were in the living room of a resident who had called 911, and she was refusing to go to the hospital, and she was extremely short of breath, and there was a lot going on for her. And they talked to her and said, are you interested in talking with a Grace to see what they could do for you? And she said yes, and they called us at 5 o'clock in the morning. And that was awesome because we were able to get there within a couple hours to see her. So anybody can make that referral, and we get it from the most sometimes bizarre places, but it's just really, how can we get this person help? So good question. Any others before I keep going? How are you guys doing over there in Verona? Okay. All right. So what does hospice provide? So we've got, I'm going to go through this relatively quickly here. I'm sure a lot of you may be familiar with this, but one of the biggest things that I think really gets people interested is home visits. So our team that is assigned to each and every one of our patients consists of a nurse case manager, a social worker, a certified nursing assistant, a spiritual and grief counselor, as well as one of our community or one of our Grace physicians, and a slew of volunteers that can be involved. And what this allows is for our team to come into somebody's home to provide the care that they need to continue feeling well, to continue to manage symptoms without them having to go to the hospital, without them having to even get to the clinic, which can sometimes be very difficult, as we all know. So that's one of the biggest, I think, selling points for people that have decided, I don't want to go to the hospital anymore. I don't want to go to the doctor. I'm sick of being poked and prodded. And so we also cover things like medical equipment, supplies, and medications that are related to hospice. This includes things like hospital beds, over-the-bed tables, bedside commodes, shower chairs, wheelchairs, Hoyer lifts. If somebody needs it and it is needed for comfort care, we will provide it. That's part of the hospice benefit. We help manage pain and other symptoms. We provide grief and emotional support for our patients and their families, which is equally as important, and their caregivers. And then if somebody needs short-term inpatient care, we call it acute symptom management. So just be like going to the hospital. They can come to our inpatient unit and we can get their symptoms managed. It's typically 3 to 5 days and they go home. So it's a nice, short, brief period of time, and most people at the end of that want to be back in their house. And then a big part of what we do is education. Education for our patients, education for their caregivers and their families, what's coming next, what can we watch for. We don't want people to be surprised. I'm sure most of you have encountered situations where there has been a big medical event and it was unexpected and everybody is shocked. Everybody is grieving in their own way, and we don't want that. What we want is we want people to feel comfortable and confident caring for their loved ones. And then respite care. Caregiver needs a break. That's important. That's very important. They can come to our inpatient unit. We can sometimes provide services for people to have respite care in their home. We work it out. It's very important that our caregivers get a break and a breather. Questions? Okay. So I'm going to go over this briefly. We just talked about it, but who's involved in this circle of care? It's what we call this here. So in the center, we've got our hospice patient. I want you to imagine a smaller little circle around that person. That's their family, their friends, their caregivers, their own doctors, their own facility staff members that care for them, the people that they know and trust and love. And then comes these folks, our staff, volunteers, interpreters, if needed. Those people are very much involved. Their doctor, our physicians and nurse practitioners, etc. Community faith support, if we need to get somebody from the community involved, we certainly will. And then how is it paid for? This is the million-dollar question. So it is a Medicare benefit, and Medicare pays for hospice at almost 100%, which is, I get a lot of questions. When I do this at senior centers and talk about our services, they all look at me and say, no. When do I get my bill for 20%? But the reality is Medicare sees this as a really, really valuable benefit for people. It cuts their costs down tremendously when we're able to manage somebody in the home, when we're able to keep people from readmitting to the hospital over and over and over again, so they continue to fund it. Same with Medicaid. It does kind of mirror the Medicare benefit. Private insurance, most private insurances now do have a hospice benefit as well. And then Grace operates a program called Care for All. Have you all heard of that? Okay, good. So I'll tell you a little bit about it. It's a program that we offer for people who are uninsured, underinsured, or unable to pay for the care that they need. And it's community funding to be able to get these folks the services that they need. And it's a really great program, allows us to care for people who maybe have insurance policies with incredibly high deductibles that their families are struggling to meet, especially knowing that one of them is going to pass. So that's very important. So our patients almost all have very, very little out-of-pocket costs. What we see they pay for on their own most is any medications that they choose to continue that are unrelated to their hospice diagnosis.
I know you have a range, for up to 6 months, care, but is there like an average cost?
An average cost for that amount of time?
Hospice care, yeah. I'm just curious.
Yeah. So we are paid on a daily rate, and I won't bore you with all the details, but we are paid on a daily rate, and Medicare reimburses us at a higher rate during the first few days and a higher rate at the end of life. And the reason they do that is they see that there's a lot more to do at the beginning. There's a lot more managing. There's a lot more organizing. And at the end of life, our care really has to ramp up. People are often seeing nurses daily at the end of life, sometimes twice a day. Their personal cares are happening more frequently. So that's kind of a bit how we're paid now. It really is going to depend on how long somebody's with us. We could have somebody with us days, and we've had folks that have been with us years because they continue that steady decline. And as long as somebody continues the decline, we're not going to kick anybody off service. So they can continue to receive the benefit as long as they continue to be eligible. And we don't say kick off, by the way, we say graduate. We try to make it a little bit more eloquent.
The reimbursement is by geography. Oh, so like being in the Midwest, it can be like $180 a day for Medicare patient. In New York, it can be $250.
Oh, okay.
Mm-hmm.
Can you, when people ask questions, if you can repeat them?
Oh, yes. Oh, yes. I'm sorry. Yes. Good. Any other questions before we move on? Hello.
Hi, sorry.
No, you're good. You're good. I'm going to talk a little bit now about some of the objectives that I want to talk with you all about today specifically. So I want to talk a little bit about the stages of dying. I'm sure a lot of you are familiar with those. You've probably seen people in different stages of dying. I want to talk about DNR status, and we'll get into that in a minute. I'm sure you're all thinking, oh my gosh, if only everybody had that bracelet on. And then how can hospice help if you are dispatched to somebody's home? And what does that look like? How can we work together? Coroner contacts. I want to touch on that briefly for you as well. When to transport related to hospice, and then we're going to touch on HIPAA. And then please jump in if you have any other questions or anything burning that you want to touch on. Okay, during the stages of dying. So what stages are common during the dying process? This is kind of a catch-22, a trick question in a sense. Not everybody's stages of dying look the same. It looks different for everybody. The end of life phase looks different for everybody. We, I'm sure, have all known or known of folks who have simply gone to bed one night and passed very peacefully in their sleep. And it doesn't look like that for everybody. But there are some things that I want to get to, and I think it's on my next slide that kind of really lists out what we're looking for. And then how do families grieve? This also is something that I think is very dependent on our families. It's very dependent on how somebody passed, what kind of education they had. Again, it comes back to us educating families and helping them understand what to expect next. I think the more we are all in control and we all feel that control, sometimes the easier it is for us to cope and understand what has happened. So that's how we sometimes work together here. Okay, some of the physical changes and some of the things that we see as folks start their descent and start being closer to end of life. So we'll see decreased appetite often. We know that as somebody's body starts to change at end of life and organ systems start to not work quite like they used to, intake changes as well, and that's very normal. But we'll often see, and you've probably seen as well, families that say, well, I just can't get her to eat more than a few bites. She won't eat. And they're putting, massive amounts of food in front of their loved ones. And our need and our caloric intake changes. What we absolutely need to continue on changes as we get closer to end of life. We see darker urine and decreased output. We'll see loss of bladder and bowel control. Also very scary for people. That's a very scary point, I think, for a lot of folks, that loss of control to be able to use the restroom. Something that I think we take for granted when we're healthy. We'll see increased fatigue, which we talked about, breathing changes. We can see bouts of apnea as somebody comes closer to end of life. They could be conscious or unconscious. We've seen minutes go by between someone taking a breath. And so that would be typically later stages. Sometimes we'll see changes in patterned breathing. So instead of just the regular in and out, we will see different patterns. It'll be quick, and then slow. But there will be that gap in between. And so there's lots of different changes in breathing that we see that we monitor and we keep track of. And it kind of helps us understand when we think we're getting to a point where we need to start to educate loved ones that the end is coming. Respiratory congestion. Have any of you heard that? When somebody takes a deep breath, they used to call it a really terrible name, and we've gotten away from it, but some of you may know it as the death rattle. Yeah, we all nod our head. And unfortunately, it's too bad that we ever called it that, but I think that's what a lot of people know it as, is that that noise that somebody makes, and it's terrifying for our loved ones. But the reality and what we know about that is that it's not hurting the patient. It's not hurting the person who's having that. It's secretions that are just kind of stuck back here, and they're making a bad noise. If any of you have kids and you have little ones that don't know how to clear their throat yet, and and you think, oh gosh, what's back there? But it's just drainage, right? I mean, we know those things don't hurt. So it's educating families on that, because that's scary noise. Fevers, we start to see spikes in fever. We can see a drop in temperature. Those things are common. Skin changes as well. Anybody here familiar with modeling? Yeah, okay, you all look for it, I'm sure. So we'll start to watch for that. We're watching for that on extremities. And typically we do see that. Again, not everybody though. So these are just things that we're continually looking for to kind of help cue us all in. Pain changes oftentimes. Somebody who may have been in extreme amounts of pain all of a sudden has none, or vice versa. Pain does change, and the patterns of pain change, and the locations of it change as well. Orientation and consciousness. Some people are conscious all the way up until they're passing, and some haven't been conscious in months. It really depends on the patient. Anxiety. Anxiety is a big one, and with that I will kind of lump in restlessness as well. Have any of you heard of terminal restlessness? Okay, so I can't see you in Verona. Yeah, okay, nobody's saying, nobody's excitedly nodding. So terminal restlessness is really just this idea that as somebody is approaching life, we see that we sometimes believe it's anxiety driven, but we don't always know. But that all of a sudden maybe they're pacing, they're kicking their legs in bed, they're just not able to settle and be. And that sometimes is a sign that the end is coming, that we should be preparing for end of life. We should be watching for that. That's just another symptom. We can see restlessness in a lot of ways. We can see it physically, we can see it emotionally or spiritually. And I do want to get to that in a minute. But it is something that we are looking for. So if families are saying, well, gosh, she just seems so restless, we want to know. We want to be aware of that, because that's a symptom that oftentimes we can help with and we can help manage. Question?
Does that qualify as like medicinal?
It can be. Yeah, it can be. Sometimes are there environmental triggers that are making somebody anxious or restless? Potentially. But a lot of times I would say we do manage that with medication. Okay. Emotional and spiritual aspects. So this idea of acceptance, I think not everybody goes through this, but we see it quite a bit, and where people will accept that their end is close. But there's also these other things. There's this fear and this anxiety, which I think is very natural, to be scared, to be anxious. I don't want to be in pain. I'm scared to be in pain. I'm scared to die. I don't know what's going to come next. And those are feelings that not everybody verbalizes, but that we really want to pick up on and we really want to be able to help with. Again, this is where spiritual and grief counseling can come in. Closure. I'll tell you a story. When I first started at a Grace, about 4.5-ish years ago, it was one of the families that I had just started working with, and they had come to the inpatient unit. And they had 8 kids, and it was like one of my very first tours. And I was very nervous. And so I do this tour, and we all sit down, and we're talking about kind of some of the services. And I'm not kidding, every kid showed up for this tour. And so we're talking about some of the services, and Mom had been admitted at our inpatient unit already. And the kids, I think most of them were really on the same page. They really just, how do we keep Mom comfortable? What can we do as her kids? And Mom had been with us for now a while. And I remember I got pulled out of the room briefly by one of the social workers who said, can you see if you can figure out if we're missing somebody here? And I said, what do you mean if we're missing somebody? She's like, just see if there's somebody that's missing that needs to come. I said, okay. So I sit back down, and again, I just started. I don't know what I was doing. So I'm talking with them, and I said, so is it just the 8 of you? And they all kind of looked at each other quietly. Oh, well, we have a brother, but he doesn't handle this well. He didn't want to come. Oh, okay. So I told the social worker, well, there's a brother. Okay. So mom had been very, very close to passing, hence why all 8 children were at our inpatient unit, because our social worker and nurse had called and said, it's time, you need to come over. And just wasn't letting go, and we couldn't figure out why she wasn't letting go. So the social worker approached them and said, is there any way we can get your brother here? Is there any way? And they said, I don't know. He doesn't like this. This freaks him out. This is too scary for him. And so long story short, they ended up talking him into coming and visiting. He came, he visited. She passed minutes after he left. And it's just this idea that there is closure, that people are looking for closure, and it's something different for everybody. So that's just a little story for you. Religious and spiritual intervention, something that we'll set up. We've got our own spiritual and grief counselors. If there's somebody in the community somebody wants to talk with, we can manage that. And then symbolic language. I need to catch the train. I need to get on the train. I can't miss the train. That's one that we hear. We hear that with bus as well. What are some others that you've heard, Carrie?
Just that however they let you guys say I got to get on the truck, that kind of thing. So when people are dying, they're talking about symbolic language, like how they lived is how they died. Mm-hmm. And they can be fairly unresponsive and still talking about, don't let me miss the bus.
I got to milk the cows.
Yeah.
So some of you may have heard that. Sometimes our loved ones look at us look at our patients like, what on earth is going on? Very normal. Very normal. And sometimes it's very moving too. Okay, DNR status. How many of you have been to a home where somebody says they're a DNR, wife says, no, he's a DNR, but they have no bracelet on? Yeah, we know. And not all of our patients, however, we want you to know, are DNR status. They do not have to be. It is something we revisit frequently. We all know what CPR on a 92-year-old looks like, and we don't want our patients to go through that if they don't feel the absolute need to be a no code. And so that is something that I do want to point out, is that if you're walking into a hospice patient's home, most of the time they will be a DNR, but there are times where they won't be. So something just to be aware of. Some of our patients are very great and they wear their DNR bracelet all the time. Some of them put it on the refrigerator, or some of the facilities have them in charts in their patient's chart. And so we do our best as an agency to encourage people to wear their DNR bracelets. We check them out when we're in the house to make sure that they didn't shower and get it all, unrecognizable. Well, we can go ahead and update those and get them new bracelets when needed. So I do want to point that out, that we are revisiting that. But it is a challenge for us as well. And we want to make sure we can make your lives easier. So if there's anything that we can do to do that, please reach out, give us some ideas, anything we can do. Have there been any challenges or barriers around that lately?
Well, I mean, it's always
always
if they're not wearing it, and a family member or somebody isn't going to put it on, we don't honor that.
Right.
Unless the paperwork is there to accompany it.
Right.
That we can verify, but I mean,
right.
It can be on the fridge all day.
Yeah.
But it's not valid for us. Right.
Do you encourage the patients to actually, like if they're at home with hospice, to actually wear it?
Yes, we do. We do encourage that. We don't require that anybody purchase like a metal one or anything like that, but we do encourage, again, we are checking those as frequently as we're in somebody's home, just to make sure that they are readable, that you can read it. That's, I understand, another large barrier there is if you can't read the bracelet, that's an issue. And so we are doing that. We can't guarantee people wear them. They take them off. They stick them in bags. They stick them on the fridge. They stick them in cupboards. We don't know where they are sometimes, but we are revisiting that. So just so you are all aware, not all of our patients are a DNR. I would say the vast majority of them are, and certainly as we get closer to end of life, that's something that's on the forefront of our mind, is helping and educating people so that they do make that decision. But we can't force that either.
I think, yeah, the more you can educate them that if they call for us and it's not on the list, I mean,
Right.
I know when my dad was dying, he like gave me one to keep in my car and one to my mom to keep in her car.
Yep.
So that if we went out, we could quick throw it on his
Throw it
list.
on.
But
Yeah.
like that, I understand that it needs to be there, but
Yeah.
someone else, they're not going to think of that.
Right.
And I think most of us want to honor, the patient's wishes, but I mean, we have an obligation to do our job also. But I mean, if we know that this is in play, there'll be somebody, trying to get it figured out, but there's also going to be things being done that they might not have wanted done at the same time.
Right. Well, and please know that too, our patients, when if a family member calls us and they're not a DNR and they have passed and we respond, it's our obligation as well to work somebody. I mean, our team has to do that. If they don't have a DNR, we understand that. And so please know that as well. But we're hoping that as we're able to educate folks more, that these occurrences become less and less and less where you're in the home of a hospice patient who has passed and is not wearing their bracelet.
If you could get some sort of a deal, or agreement with like the places that provide the pretty DNR bracelets.
Yeah.
I mean, because at Chapel Valley, the ladies all want, the pretty bracelet. They don't want to wear the paper ones.
Right.
So, I mean, if you can, make some sort of, hey, there's a business, right?
Yep.
Some sort of, something so it won't cost as much or, whatever.
Uh-huh.
Just, that might make people more in tune. Some people wear one.
I agree. Yeah, I agree. Oh, that is funny. All right. So how can hospice help if you are dispatched to the home of a deceased person? So we oftentimes, our nurse case managers will pronounce our patients, and we will fill out paperwork that is necessary. We will do all of those things. We do destroy medications if a family wants this completed. So if there are medications that are left in the home, those are things that we can do. We oftentimes have relationships with the family. We have these relationships that we've been working on for hopefully months. And a big part of what we do at those death visits is comfort and be there for families and help and support them through this. It's a very scary time oftentimes. Doesn't matter how prepared we are. Sometimes it's still very scary. And so we very much want to be there to support them. Also can make your lives a little easier. Sometimes supporting a stranger isn't always probably the easiest thing. And maybe sometimes they just collapse in your arm and they make it real easy. But hopefully that would support you as well. Making those phone calls to primary care physicians to notify them of the death, to the coroner if that's necessary. I'm going to touch on that in a minute. We arrange for funeral home pickup and transport, and then also clergy. So if there's faith leaders that our patients wanted notified of their death, we can be there to do that as well. Okay. Coroner contacts. So hospice patients, we pre-register with the coroner if necessary. So the coroner is notified at the time of death. They normally don't respond to the home of hospice patients, which may be different for you folks that are working with folks that aren't hospice patients, but typically they do not respond. And then we will review medical history and information such as falls and determine if it's a coroner case. So if somebody wasn't pre-registered with a coroner and there's a fall 24 hours earlier, we may review that and determine if the coroner needs to be contacted at time of death. So those are some ways, hopefully, that we take that off your plate as well. Again, I think it just comes down to the communication piece. And now I think is a great time to touch. When we met with the Madison Precinct, West Precinct a couple years ago, one of the things they said is, how do I know if I'm walking into somebody's house that they are a hospice patient? And we said, great question. If they don't tell you, sometimes that can be a barrier. So one of the things that we worked with them on and came up with was this idea of a whiteboard. Now this is a whiteboard that has two little stickies on the back. At every admission visit, we stick this on the refrigerator. Now, we know if you are being dispatched to a home, you don't always have time to navigate through the house and find the kitchen and look at the refrigerator and read it. So we understand that. We hope that this is a tool for you to use as often as you can. So some things that we put on here, we can put information about the patient that we're caring for in the home. There's a little checklist here that says, please call a Grace if there's a fall. You need to go to the emergency room. So if you're looking at transporting somebody, we would like to know. Oftentimes we pay for that. So it is important that we are aware that somebody's going to the hospital. Also, we've had a couple EMS groups in town who have called us and said, hey, just want you to know we're taking your patient over to Meritor. They're asking to go. They want to go. And we say, okay, great. We'll meet them there. And we meet them at the hospital, and we advocate for them at the hospital. And we are there for them at the hospital with whatever needs to happen.
Could you go back 1 second?
Yep.
So does hospice pay for the ambulance trip as well?
Yes. So if a trip to the hospital is related to the hospice diagnosis, this is where it gets a little funny, then yes, we do pay for the ambulance transport. However, the only person that can tell you if it's related to the hospice diagnosis typically is the hospice team at a Grace. And so I would say most of our folks that end up going to the hospital, there's some sort of relationship, and it is related somehow to their hospice diagnosis, but not all. So I know that muddies the water a little bit, but I would say a good chunk of the time we do pay for it. But we try to have those conversations even before somebody is transported if we can. So if you're standing in their living room and are able to give us a heads up, we can make sure and look into what happened and is it related and will we cover it.
Okay, thanks.
Yeah. And then are there pain or symptoms? Are they getting worse? That's another reason that somebody would call. Is there a need for medication changes? That would be another reason that we would ask to be called, or refilled or something else. So that's just a little check box mark thing on the side here for just people to understand. And then we also have here, call a Grace first at, and we're going to put our phone number for you. So you're not trying to Google what our phone number is. And then what's the reason that you're calling us? And then any emergency information. So we're going to put things on here like DNR status. We're going to put things on here, if applicable, things like if there is a primary diagnosis that you need to be aware of. Are you walking into the home of somebody who has frontal temporal lobe dementia and very, very active and has behaviors and has a history of behaviors? Something for you to be aware of, safety reasons. So again, this is a tool for everybody to be using, and we've gotten really good feedback on it. I hope you've seen this. Have you all seen this? Okay, good. Yay. It's working. So I hope, and as you are viewing this and there's other information that you feel would be helpful, please reach out. Please reach out, yes.
Is there someone that answers that line 24 hours a day?
Yes. Yes.
Okay.
Yep, there's a nurse that answers our phone 24 hours a day. So should you need something, it is triage nurse. We can get visits out there. We can get somebody out right away. So if, again, like what happened in Middleton a couple weeks ago, if you've got someone saying, no, I'm not getting in your ambulance and you're not taking me anywhere, but there may be a patient of ours, give us a call. We can usually get a nurse out there very quickly, somebody to respond, and hopefully manage what's going on. Okay. When to transport. We've kind of talked about this, so I won't beat a dead horse here. But hospice will call for a transport to a local hospital if we need one. So if there's a reason and something that warrants a hospitalization, and the patient and family want that, we will call ahead for that. And then family can call. So if family calls you, again, you get a phone call from somebody, you respond, and turns out they are a hospice patient. It's, again, important that we are notified so we can meet the patient and the family in the hospital. We do review their goals of care. If somebody fell and had a broken hip and wanted their hip repaired, we most likely would have to talk with them about what their goals of care are. Is it comfort? Can we manage you at home and keep you comfortable with a broken hip? Or is it necessary that it's operated on? So we talk through every situation, and every situation is different. And then we can facilitate another level of care if needed. So if somebody is transported from Chapel Valley to Meritor and they're unable to return because their level of care has gone up, we can help with discharge planning. We can help get somebody into a skilled nursing home. We can do that from a home as well. If it's an unsafe situation at home and we need to find a safer living space, we can help with that too. Questions on that? I know you have your own protocols, and by all means, please follow your protocols. This is in no way to get in the middle of that. Just communication, I think, is what we've kind of come back to time and time again as being key. Okay. HIPAA. If you call a GRACE, when you're in somebody's living room who's in a GRACE patient, are you violating HIPAA? Trick question. Just kidding. No, you're not. And so we can communicate and we can share information for a couple of reasons. We can share information to facilitate treatment, and we can share information for operations of care. Those are the two reasons that we should be able to communicate with each other. And again, if you're talking with a patient, you're talking with a resident who you've been dispatched to, and they're refusing transport and they want you to call a GRACE, by all means, please call us. And we are happy to respond. But it does have to fall under one of these two categories, usually pretty simple for all of us, I think, when you're dispatched and we're involved. So if there's ever questions on that, please let us know. Any other questions?
What is your guys' time frame that you guys like to be out to people? So say we're on scene with somebody, and we've had it happen before, where somebody is not able to be by themselves.
Mm-hmm.
They are falling, we try to road test them, they fall again, we say, we can't leave you here by yourself.
Yeah.
Or they're with a spouse, and and they're not sure
Can't
what
care
to
for them.
do, or
Like that. So if they, by our protocols, can't refuse, if a GRACE comes over and says, yes, they're refusing, and we talk to our doctors, and I mean, it just becomes, quite frankly, that the rubber the pissing battle at that point.
Mm-hmm.
For your protocol, do you have to respond within a certain amount of time, or do you guys have a goal of getting there?
Yeah, so the question is, do we have to respond to a resident's home within a certain amount of time after being called? So what my initial thought is, and Carrie, you chime in, if you have a protocol that says, no, this person needs to be transported, our physicians are saying transport, and they're asking you to call a GRACE, please give us a heads up, but do what you need to do to keep that person safe. Our admission team, if this is a brand new resident to us, is usually able to get to somebody's home the same day. Now, what that means is it could be in 45 minutes. It could be in 4 hours. It all depends on the day, frankly, probably often like your days go. So if you have a protocol and you're saying this is not a safe situation, please by all means follow your protocol and do what you need to do. If this is a patient of ours already, please give us a call and we can give you an ETA. So if you're saying, well, it's not a crazy busy day, I can wait 30 minutes for the nurse to get here and hang out while I wait, great. If you're saying, no, I'm really sorry, I've got to transport this person, tell our nurse that, say, this is not a safe situation, we have to transport, and we'll meet them at the hospital.
What do you usually do? I mean, what's your protocol? What do you guys?
So our steps are, like, if they're of competent mind but they can't take care of themselves, we can't just leave somebody sitting there. And we'll probably transport them up to the hospital unless a GRACE or whatever end-of-life care that they have in place, unless they say they can be there within a reasonable amount of time, because we're not, sorry to say, we're not private EMS, we can't wait around all day.
Or even a half hour is a long time.
Yeah, half hour, 45
that's what I'm
minutes.
thinking.
And that's somewhat reasonable, but in the same sense is we're still tying up a 911 response rate.
Right.
So take them to the year.
Mm-hmm. Follow your process.
They're safe. You can go on to your next call.
What are nursing homes kind of told when someone has a fall or has a
Mm-hmm.
reason that they need to be possibly transported or evaluated? So I mean, it's kind of been a controversy lately. Well, what we've called hospice, they don't want them to go to the hospital. But I guess my thing is if they're on a blood thinner and they've fallen,
Mm-hmm.
how are you going to be able to assess them? You know what I'm saying? So I guess like there's maybe a gray area with nursing homes. That sounds.
Yeah. So the question is, what's the nursing home policy, and what are they being told as far as transport? So that's a really good question, and it does vary. Each nursing home has their own preference and their own way that they like to do these things. However, what we do request is that if there is a fall of a patient of ours or some other medical event of a patient of ours, that they contact Grace first. And most of these folks don't want 911 called. They don't want to be transported. And I would say most. Some do. Some say, if I fall, please get me to the hospital. And we honor that. But most don't. So we always ask them to please call us first. We also ask our home patients to please call us first. Call us before you call 911. Because we have to also, I think, put ourselves back in the mindset of these people, which is they're really focused on comfort. They just want to be comfortable. They don't want the workup. They don't want, so if they're on a blood thinner and they do fall, do they want to be evaluated? That's another question. So we work with them on that, and everybody's different, and every situation is going to be handled differently. But if they contact our nurse triage line, they will talk them through the situation. The nurse case manager can usually respond during the day and get over there and do the assessment. And if we see somebody and we decide, yep, ambulance transport's necessary at this point, we will call for that.
Right, and I think we've run into it a couple times, at least my crew, where we don't know that patient's baseline mental status, so we don't know if they're having some sort of issue from falling and hitting their head or whatever, so it kind of just becomes a little bit of a, well, in a sense, yes, right? But I mean, it has to be, so it's, we don't want to take, you can wait and talk to hospice, and then it's kind of turns into, so we kind of just err on the side of caution and transport them.
It's the best, and it's fun, and we're happy to come to the ER. And a lot of it's based on regulation as well, so you're right, and then right. If the nursing homes, if somebody hits their head, they have to go. It's just part of the gig, so it's fine. And we're happy to meet them in here. And you guys need to be free to go to your next time.
Yeah, absolutely. Yeah, and we do. I mean, we meet them there frequently. So, if you've got a question about mental status, feel free to give us a call. We're happy to talk through it. But sometimes you don't have time to give us a call either. We recognize that and we respect that.
So we've been talking about people that are at home or nursing facilities, so the people that are at the Grace, which is in Fitchburg, so I mean, we are familiar with it. Is there a protocol for when we respond to, I know there's family members we've responded to there, but I mean, when it's a patient that, like, on your end, is there a protocol as who has to decide if 911 is called?
Yeah.
Or who makes that determination? Because there's been some confusing, instances where we've been called. And so I was just curious on your end, how does that work for a patient?
Yeah, so the question is on Grace's end at the inpatient unit in Fitchburg, who makes the decision on when to call 911 and when that's necessary? I don't know that I have a great answer for that. Our team, we have physicians and nurse practitioners and nurses that are all housed in that building. My guess is they all make that call together. If a patient or family is requesting that 911 is called, we do have to honor that, and we will. If they want to go to the hospital and be treated there, we will.
And if they are not in the air. If patients come in and they're still not willing to be, do not resuscitate, then we call 911 to take them out.
Do you ever call if them or their family or power of attorney don't want 911 called? Can you ever override that, or do you respect their wishes?
It's a good question. I don't know the answer for you, but we'll find out. And I'm thinking what a great conversation this would be for our medical director.
Yes.
At some point you talk to that. That would be helpful for the next round.
Sure.
Mm-hmm.
I think that was pretty eye-opening about 4 years ago when we went to work with code and Grace for a patient there, and we said, I thought they all had to be DNR, and it's like, well, kind of not really.
Yeah, no, this has
You
been
can't
very
require it.
informative. I mean,
Good.
yeah.
But the
Good.
next level would be one of our medical directors, for somebody who's more
Yeah.
legal, your heart
Sure.
stopped, whatever, and we're happy to bring someone over.
Mhm.
Any other questions? Okay. Well, thank you for your time this morning and your attention. I hope this was helpful. If there's anything pressing, please let us know. We're happy to answer any other questions as they come up. But thanks for everything you guys do and taking care of these folks because we know it's not easy. So good. Yeah, thank you.
And are you okay with us sharing the video of this?
Yeah, that's fine. Do you want me to just leave? Do you want me to leave?